My name is Dr. Andres Fonseca. I am a consultant psychiatrist. I'm also the CEO of Thrive, and I still have a clinical load. So I still have patients that I see regularly, and it just so happens that my patients are elderly, the ones that I have directly under my caseload, and I've been monitoring this situation very closely, just because my patients are at a particular risk from this outbreak. So I thought that it might be a good idea to share what I've learned with everybody, and I think that increasing our knowledge might be helpful. I do want to sort of devote some time, particularly towards the end, to looking at what are the possibilities, what are the things that are coming down the pipeline that may help us really minimize the impact of this crisis. So yeah, while I am a doctor, I must say that I'm not your doctor, so I cannot really answer any specific questions about any specific symptoms or anything else that you may be having. That's a conversation that you should have with your own medical professional, your GP, or any other medical professional that you have access to, like a nurse practitioner, for example, from your surgery. I will answer questions towards the end. It'll be more about the things that we've spoken about, more in generic terms about the disease itself and the virus. And I expect this to last approximately 40 minutes or so, depending on the questions that we get. With me is Emily Cook, who is one of our business psychologists in Thrive, and she's going to be monitoring the questions and everything else. I don't know if you want to say anything, Emily?
I'll just say hello to everyone and thanks for joining.
All right, so let's get started. The things that I wanted to cover, if I get my PowerPoint to work, are these. So I wanted to talk about the condition. What is it? What causes it? What do we know about the virus that is causing it? Some insights from epidemiology in general about how it spreads and how we can best prevent it. A lot of this is known thanks to the very good information campaign from the NHS and the Department of Health. But I just wanted to sort of perhaps give a little bit more detail. And I wanted to sort of talk about how the body can affect the body, so how the virus can affect the body. There's very many different presentations, it appears, and also what are the possible new directions, things that might help us in the coming weeks, months. It's going to be months, but there are some very hopeful developments. So I wanted to share those with everybody. So what the virus is completely new. That's one of the issues that we have. Is in this coronavirus family. So when people say coronavirus, there are many. My formatting is gone. I see there. So there are 7 now 7. There used to be 6. There's now 7 human coronaviruses, and there's like those 4. So it's 229NE. NL63, the OC43, and HKU1. Those are the ones that circulate normally. They're very common, and they have a seasonal presentation. They affect us in the winter, and they are the ones that we call the common cold. They largely cause that kind of a presentation. Now, we have others, which is the MERS, SARS, and the new one, which is the last one on that list, is the SARS-CoV-2. That's the name of the virus. So the thing is that coronaviruses, there are very, very many. Many infect animals, and sometimes they evolve to infect humans. And this is what happened in the last 3 cases. There were viruses, there were coronaviruses that were present in animals, and they changed, they evolved, and they infected a person. And then the viruses started spreading from person to person. That is the new thing. So this is like a picture of the virus. I really like it because it's one of the most detailed and clear that I found. It's got everything you want to know about it. So one of the interesting features is that fatty membrane. It's called lipid membrane on the diagram. That's an interesting feature. It makes it so it's a relatively big virus, and that protects it against things. But that's what, you know, when you scrub your hands with soap, and when you use alcohol-based sanitizers, that part of the virus is particularly vulnerable to that, and that's what really kills it. We also have this spike protein. That's a very, very important feature, because that spike protein is the one that the virus uses to gain entry into the cell. So those are two important features to bear in mind. This is a diagram that I found from those sources. Also, I mean, it's a very good picture. It was published in the Economist. I really like it. It's much better than the original ones in the papers. So I decided to use it. And it just gives you the whole life cycle of what happens. So basically, it gains entry by using that spike protein and binding to this receptor, which we have in our bodies, which is the angiotensin converting enzyme 2 receptor. That one there, it's just normal, we have it. And it uses that TMPRSS2 little transmembrane protein to activate that S protein. So then you can see that it makes a little bubble, and then the bubble, the virus gets sort of approaches the edge of that bubble, and the bit in the middle, it's got RNA, not DNA, comes out, and that immediately starts making proteins, and it starts making a way for it to duplicate itself, those proteins. And then it goes into that bit of that factory in the cell called the Golgi, and that factory is what makes a new virus. So it's kind of hijacking the cell to make more of itself. So it uses the production facilities in the cell to make a lot more of itself. And because it sort of drives it to do this over and over and over again, the cell cannot keep it up, and eventually it dies. And as you can see, when it's doing that, when it's forming the new virus, it creates another little bubble, and then that bubble gets fused with the outer membrane, and that's where the virus comes out of the cell. So all those processes are important, because they are what we look at when we're looking at what kind of medication we can use, what kind of drugs can we use to deal with it. So that's why this is interesting, and I'll talk a little bit about some of these things later. So the virus lasts for a long time on surfaces. There's a study there that I mean, everything I'm saying comes from a study that I've read, and I've listed all the studies on the slides. So if you're curious about any of these things that I'm talking about, you can get more information from the studies or from the links themselves. We'll make sure that we share the slides and the presentation after I deliver it. So it lasts for a long time on surfaces. You see there a range of hours that it lasts depending on the surface. The reason that's so specific is because that's what the researchers specifically tested. So that's the information that we have, what they specifically tested. We don't know that warm weather will affect it, or warm anything will affect it. We don't know that sunlight will affect it. I'm saying these things because I see some memes circulating online talking about those things. Some of the things that you may have heard is that maybe younger people are completely invulnerable. That's not true. It can affect all ages. It spreads in these large droplets from coughing or sneezing. Asymptomatic people can spread it. I'll talk a little bit more about that later. And you can have a lot of viruses in your nose, even if you have no symptoms, which again is what part of the issue, part of the problem with this particular virus, and why it's proving so tricky to deal with. Now, I've got the base case reproduction rate is some studies put it at 2 to 6.5. That means for every case, how many other cases are you likely to get? So that's an accumulation of various studies. But in Europe, according to the European Center for Disease Control is pinned down at the moment to 2.76 to 3.25. Now, the issue is that if you compare it with the SARS, the original SARS, that base case reproduction was around 2, and the flu pandemic, which you may remember, was 1.3. So this one is a lot more effective. That's part of the problem, part of the reason we're having such an issue with it. So the COVID-19 is the name of the illness. So we've got the name of the virus is that SARS-CoV-2, and the name of the illness is COVID-19, which makes it a little bit confusing. So the illness is currently described like high temperature, difficulty breathing, and coughing. Those are the symptoms that the CDC, the WHO, the NHS, they tell us to watch out for. And I put the rates at which those can present in known cases. Okay. Now the cough, it used to be said that it was a dry cough. It can be productive. You can have phlegm coming out, and it's not, doesn't rule it out at all. Now the problem again is that many other presentations have been described. So again, the CDC, the ECDC is reporting all the presentations which come with sore throat, general weakness, pain. Previous reports from China and other places. We have also fatigue, sputum production, as I was saying, phlegm, sore throat, headaches, pain, diarrhea, and vomiting. Now, a more recent German study, which has not been peer-reviewed yet, I must say, also shows very mild cases with symptoms that resemble the common cold. So that's important because case identification might prove harder than we thought. And more recently, there's a statement from the American Academy of Otorhinolaryngology, so ENT professionals, that shows anecdotal evidence suggesting loss of smell as one of the presenting factors, or one of the presenting the way that people can present to services with no other symptoms. So that again, that's not been peer reviewed, but it's a report from the American Academy of Otorhinolaryngology. So the problem that it has is that in a small percentage of cases, it creates this acute respiratory distress syndrome. Small, it's hard to estimate how small. I'll talk about the numbers later, but it's around about, the highest estimate is around 20%, the lowest estimate is around 16% or so. In some cases, this obviously, as you know, has led to death. So there's the risk factors for these individuals are being of an older age and having more than one, so one or more than one organ problem. So they may have breathing problems, they may have a neurological condition such as maybe dementia, Parkinson's disease, and others. They may have a heart condition, kidney disease, liver disease, and coagulation. And it's assessing all of those and looking at how badly they are affected that we can get this score, this systematic organ failure score. And we know from the Lancet study that I'm quoting at the end that is a very good indicator that can tell you whether somebody is likely to develop this more serious presentation or not, depending on how many of those are affected and how badly those are affected. Coagulation is in that organ failure assessment. Coagulation seems to be a particular risk factor, and that's why that test that I quote there seems to be an indicator of risk. Just that test alone, independently, seems to be a risk factor. So that D-dimer test is a measure of coagulation. Okay, so you might be wondering, why is it that older people are more susceptible? This is like very, very commonly. I mean, you might expect that if you have other physical health conditions, then obviously you might be more vulnerable. But why older people? Why are you more susceptible to getting it and getting symptoms, severe symptoms from it? We think is that receptor that I showed you at the beginning, the angiotensin converting enzyme 2 receptor. I'll show you the picture again. That one on the surface that little glove that catches that spike, that's the one that seems to be more present, more present in people as we age. So there's more of that in our lungs, for example, in our respiratory tract, in our bodies as we age. People who smoke seem to have more of them, so they might be more at risk. There's some studies undergoing looking at that. And some blood pressure tablets can increase the presence of those receptors. So again, maybe people that have been taking those blood pressure tablets that have more of those receptors, they may be more susceptible. So all the vulnerabilities that we know about are to do with having physical health conditions. And we know that the risk increases if you have one, and more if you have two, and if you have more than two, even more so. The ones that have been clearly linked, I've got them there. So diabetes, heart disease, chronic respiratory disease, and cancer have all been reported as increasing that risk. Of course, those are all more frequent in older people, so that might be also part of the issue. Now, women do better than men. You may have heard this. We don't know. Women don't have any less of that receptor than men, so it's not that. But maybe my speculation, and please take it with a grain of salt, is because they tend to have less of these comorbidities. They tend to have less of these compromised systems. So we all know that women tend to live longer, and it's because they have less of these age-related conditions as they get older. And maybe that is why there may be a difference between men and women. Men may be more likely at the same age to have more of these, one or more of these conditions. So this is the picture of, again, this is I think I got this from the European CDC yesterday. So this is, yeah, there you go, data is up to 24th of March, just yesterday. And this is from the reports in Spain, Germany, and Italy, which you know that have a lot of cases. So this is what it looks like. Of course, Italy looks the worst because obviously the healthcare system is overwhelmed, and you get more deaths really if your healthcare system cannot cope. That's why the government is insistent on trying to prevent it as much as possible and not limit the spread as much as possible, because if your healthcare system gets overwhelmed, you get a picture like the one that we have from Italy. But you can see that all the people, the older you are, the more at risk you become. And it does really shift very, very dramatically from the age of 60 to the age of 70, and from the age of 70 to the age of 80, as you can see in those graphs. So what are we doing? What can we do? So the reason we're doing this distancing for the whole population is because a lot of people have those mild presentations, and a lot of people have no symptoms at all. And because the incubation period is so long, we are spreading the virus when we don't even know that we have the disease at all. We're not showing any symptoms. So that's why that is kind of the only solution, unfortunately, at the moment. So I will comment more on gloves later, but the important thing is to, wash your hands effectively, 20 seconds with a good technique. That fat virus that I was talking about is very fat, and you can remove it by the scrubbing action. That is the most effective way of doing it. Alcohol-based sanitizers, those are effective. It's always preferable to wash your hands if you can, but if you're out and about, it may be much better to use the hand sanitizers because you have access to them. So that makes sense. Cleaning frequently touched surfaces, because we know that it can last for quite some time on surfaces. Respiratory hygiene, very important. They recommend sort of sneezing or coughing into your elbow, but it's much more important, it's much better, sorry, if you can use tissues and throw them in the bin. Much more effective. This is easier said than done. Avoid touching the face. I'll comment a little bit more on masks later, but basically people who are healthy and wear masks, I've seen them. around, and they tend to touch their face a lot to adjust that mask. So, I mean, I don't know, maybe they're making it worse for themselves in some ways. So there's a thing that there's a paper that was published by Imperial College. I've got the link down below there if you're interested as well. And this is the modeling. This was published on the 16th of March, and that's what made the government change course. They were going for a less restrictive strategy to begin with, but the modeling looked at the effect of all those cases. What happens if we close schools and universities? What happens if we do only case isolation? What happens if we do just voluntary quarantine when people are unwell? What happens if we only do social distancing for those that are most at risk? And what happens if we do social distancing for the entire population? And it shows that the only way is to introduce all those measures in order to avoid completely overwhelming the NHS. Why is this? If we only have a small percentage of cases that are severe, because if the whole population, if it's spread through the whole population, a small percentage of cases is, you know, millions of cases, right? So if you think about the population of the UK, and the population of the UK is 63 million, and we're thinking that maybe something like, imagine there is a lowest estimate that 16%, 17% that develop the more serious condition. Well, that is millions of people, and millions of people in a short period of time is just not something that you can deal with in a healthcare system. So that is the big problem. So here we go. Masks are not useful in healthy individuals and may create a problem because people are touching their face. They wear them for very long. They're not effective if you wear them for very long. And also you are depriving healthcare professionals of them, which is harmful, clearly. So they are useful if somebody is ill in your household, for example, and you are helping them. They must have their own bathroom, and they must sort of be in relative isolation from the rest of the house. But wearing a mask while attending someone ill is appropriate, and of course you're only doing it for the periods where you're tending to them. That's what health professionals do. That's how those masks are normally used. If the person has symptoms, it is actually quite useful for them to wear a mask to protect others. So healthy people wearing them is not great. Gloves, they are useful to protect others, again, and to stop the spread, but mainly in care settings, because you're not going to use them like they're used in care settings. So the problem is, if you touch a surface, the virus is not going to get into your system. It's only through your eyes, your nose, your mouth that it can get into your system. So those mucous, surfaces in your body. So if you're touching with gloves and then you touch your hand with the glove, you've done nothing. You've prevented nothing, and it might prevent some people from doing the thing that you need to do, which is either wash your hands, preferably, or use a hand sanitizer. That's what really is going to sort of change things. So that's the thing about gloves. So why is it so hard? Because it transmits very easily, and it doesn't seem that you need to be exposed to a lot of viruses in order to develop the condition. It seems to be spreadable before any symptoms develop, so you don't know you have it and you're spreading it. The onset might take about 14 days in which you can be spreading the viruses. The average is 5 to 6 days, but it can be as long as 14 days, and the WHO is now telling us to bear those 14 days in mind. So it can be it says completely symptomatic. That is a mistake on my part. Sorry, it should say completely asymptomatic. In fact, I'm tempted to correct it now in real time. So it should be asymptomatic cases for that one. So completely asymptomatic cases are estimated 1 to 3%. This is the update, the 7th update. I think it was there was a mistake there as well. I think it's published in on the 16th of March, not the 25th. No, actually, it's the last one. Yeah, it's the last one. It's the 25th of March. Mild symptoms are very frequent, and again, this changes and it's changed over time. So when more and more proactive testing is done, you get more mild cases. When testing is done in only the population that is presenting with some symptoms, then you get fewer mild cases, because only those that step forward for testing get counted, if that makes any sense. So, but it's around that. It's around 83 to 70%, depending on the reports. But I think mild symptom is mild symptom percentage is an underestimate. So it seems that you can shed the virus for a long time after the condition has stopped. So again, now we're thinking about how long after the symptoms have passed you need to be in relative, you need to keep isolating yourself, because it seems that it can go on for quite some time. I don't think we have any clear guidance on that yet, but it's not going away as soon as the symptoms go away. That is clear. And viral load seems to be high in people with no symptoms, those in the incubation, and also those a small percentage probably that don't have any symptoms whatsoever. This one just gives you an idea of how long it takes to recover. This was a trial of these two antiviral agents that are used in HIV that were tried with COVID-19 with no effect in this particular case. But I use the graph because it gives you like an idea of how many people are recovering and how does that look like. So as you can see, by day 20 after onset, most people seem to have recovered if they're going to recover. I wanted to sort of talk about the South Korean example because it's something that is in the news and it might be worth thinking about. So they were hit very early, as you know, and they've developed a strategy that seems to show very good control so far with that flattening the curve effect. So if you can see that graph that I put there on the right side of the screen, the dots, the distance between one dot and the next doesn't seem to be very large now. So the number of cases day on day seems to be quite small and decelerating. So they had a rapid acceleration phase, and then now with the strategies that they have in place, they seem to be decelerating quite well, quite nicely. So they intervened very fast. They took it very seriously, and they were very committed to the strategy. They decided not to lock down, so they're still open. You can go to a restaurant there, etc. And you can go to the office, etc. So the policy that they adopted is this extensive testing. So they're testing everything and everybody that is even mildly suspected of having it. And every time they identify someone, they will trace all contacts. So they will, and then they will subsequently test, if that makes any sense. So if you test positive in one of those tests that they're carrying out, which are extensive, as I say, then they would track all the contacts that you've had and test them as well to get a very clear picture. And then they do isolation in those cases that they detect. So they very rapidly managed to scale this, and they're doing a lot of testing outside of clinical facilities, quite safe testing. So they have these kind of booths you can even drive through. So there's a good description of what they did in that New York Times article that I'm quoting at the end. But basically, it's quite safe. So you enter and you're in an isolated space, thick rubber gloves. A technician will do a swab in your throat, and they will get a sample and they will test on that. And there's like no real contact between the technician and the person being tested. So it's quite safe way of doing these tests. And they're now scaled up the production of these tests to about 100,000 per day, and they're exporting it to other countries. They also do this temperature monitoring. So the temperature, they've got temperature cameras in restaurants, offices, and other places, and you have to sort of you have to agree to have your temperature read in order to access any public area. They have these apps that tell you where you can go for testing and to self-check. And when you do have a positive test, then they have these apps that monitor the people that are tested positive so that they can be tracked, and people agree to be tracked. I think they have particular characteristics. They have this high social adherence to policy, so there's high social trust in the government, and that may be a big factor for them, and why they managed to institute these measures without having to lock down. So the problem with this is that it might not be so easy for other people, for other countries to adopt, depending on what the culture is, what the trust in institutions is, and all of those other factors. But it's an interesting case study. So what are the therapeutic targets? What are the places where we think we can have an effect on the condition? I just talk a little bit about some of the things that you may have heard, like hydroxychloroquine. I think, unfortunately, President Trump has been talking about that without really knowing whether it's going to be effective or not. So there was this in vitro success published in Cell, but that was just in vitro. So we really don't know whether it's going to work or not. It does work on the receptor and also inhibits that process of creating, vacuolization is the process of creating those bubbles that I showed you earlier. So if you stop the virus from creating the bubbles to come in and to get out, then you stop it from spreading, right? So that's kind of the hope, because this hydroxychloroquine is an immunomodulator, and it does those kind of things. We know that because it's used in malaria, and it's also used in autoimmune diseases as an immune modulator. So that's why. The reason it's attractive is because it's already approved. So you don't need to go through the whole research process. It could be much quicker if it's actually successful in the end in any measure. It could be much quicker to get to people, but we really don't know. And I mean, most experts say that it's probably 50-50 chance that it's going to work. We don't know. So I've got a trial there if you want to sort of take a look at it, and then they will be reporting the results as time goes by. There's more than one trial. You remember that little protein? It's got this transmembrane protease that I showed you before. That one could be a target. There's no, as far as I know, there's no clinical trials for that one, but it could be a target. It could be a therapeutic target, less risky than the receptor itself. So we'll see. Remdesivir is quite promising. It was already an investigational antiviral, broad spectrum antiviral drug, and it showed promising results in other coronaviruses in animals. So there's trials already, and it needs to go through the whole process, unfortunately, and then we would need to scale up production of it. But it shows promise, so I'm hopeful that we might see some good results there. Vaccines, as you've heard, it's going to take a long time to develop them, but multiple trials have already started. So we already have candidates, which is very good. It's a very good start. They will take a long while to complete because they have to go through all the process, phase 1, 2, and 3, which is a long and tortuous process. But I'm heartened by the fact that we have multiple different vaccine candidates in trials now. So that's very good. That's good news from my point of view. These antibodies, so what you do is you gather them from people that have recovered. You may have heard this referred to as convalescent serum. So that's a good hope, right? So you gather and purify them from people who have recovered. And then we have multiple versions of that, of those antibodies. And we have various trials in progress, which is, again, very good. Because they are human antibodies, they could be faster to come to market and be helpful. I think they will probably play a role in our healthcare professionals to protect them. And it also may play a role for some candidates who have the severe respiratory disease that I was talking about earlier. But the problem with that is the scalability. Producing mass amounts of these antibodies is going to be really tough. So scaling that up is going to be difficult. I do have some hope for antibody testing. So instead of testing directly for the presence of the virus, what we're doing here is we're testing for the presence of the antibodies. So because we know there's some cases that have like like a cold type symptoms. So you have like a cold, or you have just the loss of sense of smell that is being anecdotally reported, or just no symptoms at all. Particularly children seem to have fewer symptoms, if any. So then we can do this antibody testing and confirm whether somebody has had the condition, even though they had minimal symptoms or no symptoms at all. And that might be very helpful when, for example, in the NHS, to help in the front lines. So if we know that there's people with immunity because they've already gone through it, then that's great. And also those people could donate their plasma, their serum, so that more of those monoclonal antibodies could be obtained. But again, so there's a clinical trial in progress for that. So antibody testing, that is being sped up, and there's one study that I found that I think started in February, which I've linked to there, just in case you're interested in looking at how that advances. I expect that we will get some antibody testing going soon enough. Scaling it up is going to be a challenge, though. So immunity and seasonality is the two things that people ask me about. So immunity, that looks good at the moment. Too early to know. Again, so that's my source at the bottom. If you want to sort of read it in detail, it's again from the European CDC. So it's a good source. It's too early to know how long it will last. We know that other coronaviruses give you 3+ years immunity. So that's the good news. There's clear evidence that people that develop antibodies after recovery. So that's a good sign that people do develop immunity after. And we think at this point in time that people are likely to be immune, at least in the short term, and hopefully longer term. We're hoping it's going to behave like other coronaviruses. So seasonality is an important question. I think everybody's talking about it in one way or another. All the coronaviruses display it, particularly the common human ones that I mentioned at the very start. So the virus does best on the low and mid-range humidity. We know this. So that gives us some hope. But we've recorded high rates of reproduction in dry and cold districts and in tropical districts with high absolute humidity. So again, that is kind of a point against it and makes us think that maybe not. So at this point in time, we have no evidence to believe that there's going to be any seasonality for this virus. That's what we are at the moment. Again, this may change. We don't know for sure. So that's what I wanted to sort of give you my brief kind of overall update and future directions. As I was saying, I hope that was useful.